afternoon's session, which is on integration at place from ambition to delivery. For those of you who don't know me, I'm Miriam Deacon. I'm Director of Policy and Strategy at NHS Providers, and I'm going to chair this afternoon to make sure that you get all of your questions answered from our expert panel. So really delighted to welcome Dr. Louise Clark, who is the Strategic Clinical Director of Strategy and Planning at NHS Bradford District and Craven Health and Care Partnership. Welcome to Becky Taylor, who's Group Director of Transformation and Quality Improvement at University Hospitals of Northamptonshire NHS Group, and that's part of the Northants ICS. And warm welcome to David McMullen, who is a Director at Newton, and Newton are our partners for this session. And we're also really pleased to be launching today a practical toolkit that you can use in your local places to support facilitated conversations with your partners and to support the development of new pathways. So we'll issue a reminder at the end of the session, but do head over to Newton's stand. They've got some publications there that we're publishing jointly today. So welcome to you all. In terms of the format for today, it's going to be as interactive as possible. So I'm going to turn to each of our panel members for a few words in a few moments, and then we're going to have a bit of a facilitated conversation about the work that they have been leading at the level of place in particular. If you would like to ask a question when we move into interactive Q&A, just stick your hand in the air and we've got some roving mics going around, or you can use Glisser, which I'm hoping that you've got used to by now, but there'll be a slide up in a minute giving you the details as to how to log into that, and you can put any questions that you like on that. They'll come up in the screen for me. So why focus on place today? I think it's fair to say that the national policy frameworks have waxed and waned around place as a unit of delivery a little bit in the last 12 months. So critically, we had the integration white paper, which placed a real premium on place. But I think regardless, we know that there is a lot of enthusiasm from our members, so from NHS Trusts and their partners, to really improve integrated services at that level of delivery. And we haven't seen your enthusiasm for place wane, despite the policy frameworks being slightly ambiguous over time. So that's why we're focusing on that level. People see it as really meaningful, I think, for their communities, and a place that they can really make some changes and do some of the heavy lifting around integration for the communities that they're serving. So really excited to hear from our panel today. Without further ado, I think I'm going to turn to probably Louise and then Becky, just to give us a bit of a vignette, a bit of a sense of your place, what it's like, and the work that you've been doing there with partners.
Thanks, Miriam. So I'm Director of Strategy and Transformation for Bradford District and Craven Place. Now, as we said, place, what does that mean? It's different things to different people. But we're part of the West Yorkshire ICS, and we're one of 5 places that make up the West Yorkshire ICS. And we're a collaborative, a partnership there across health and care. And we've very much, so I have another role as well. I'm also a GP at an inclusion healthcare practice 1 day a week. And the real advantage that I have is that I sit and discuss strategy, transformation, the big changes that we need to make, but also sit face to face with some of the people who struggle to access our services the most. And actually, it's that reality check between what we're doing and how much of a difference we're making is a real privilege. And I think that's something to really hold on to, a bit of a test for me. One of the roles that we're leading on at the moment, so I'm programme directing our Healthy Communities programme. We've just reset our strategy across our health and care partnership. And one of the founding principles that we've got is something called inverting the power to act, which sounds really jargony, but essentially it's about doing the right things on the right footprint with people, with communities, and moving some of that power, the resource, that decision making to where people are and doing it with them. So that's really fundamental to what we're doing. We're fairly early in our journey in terms of greater integration. We've got lots of brilliant examples, lots of promising practice. We've had some great stuff done around care coordination. But what this is about is building a really strong infrastructure on each of these layers. And our principle is really about this inverting power to act is if you can change something, if you can do the right thing on a person-to-person level, do it. Let's trust our staff to be able to get on and do that, make those changes. Where we can't do it on that person-to-person level, we've got community partnerships. They're made up of PCNs, so primary care networks, but much wider. They bring in social care, they bring in our local authority areas, our wards into there, and they bring in a really strong VCS group. Where we've got 13 community partnerships, where those are too small to be the right delivery model, we're building a new layer which is about locality collaboratives, and this is where we're really looking to integrate so that we're working much more with all of our community services, bringing them out into locality footprints, but also connecting up with neighbourhood models within the local authority to wrap around where people are. The police work on those kinds of layers as well. And then where it's not right to do it there, we've got a whole once at place piece, and where it's not right to do it there, we then go to that ICS level. But it's a real flip from where we tend to start with NHS policy, that we start at that easiest kind of footprint, that bigger footprint. But this is really about starting it in a different place. And we've actually got ways to have money and accountability flowing at that community partnership level and that locality level.
Thanks, Louise. Really interesting. Think about those different layers of population, and we'll definitely come back to the money flows and the accountability when we get into questions. Thank you. That's a great intro. And Becky, do you want to just give us a flavour of your place, or the places that you've been working with and what you've been doing?
Yeah, so I'm Becky Taylor. I'm Director of Transformation and QI across Kettering and Northampton Hospital. So we are a hospital group in Northamptonshire ICS. We are the 4th smallest ICS in the country, so we have 2 places. We have West Northamptonshire and North Northamptonshire, and we have a district general hospital essentially in both places. So to some degree, our places are quite well bounded in terms of institutions. I'm also the executive SRO for our integrated care across Northamptonshire programme, which at the moment is a transformation programme which is transitioning towards being a collaborative, which is looking at providing enhanced and integrated care for our over 65 population. So we've been running as a transformation programme for around 2 years, and we're just starting to look at what might that mean in terms of a framework for delegation of authority and financial flows and what that might look like. I think we have, because we're a small ICS, we've actually started a lot of this kind of ICS-wide. We've got a lot of work which we've been doing with our PCNs and our local area partnerships. Very similar, you know, how do we really wrap those services around and bring the community services into that kind of PCN and place level. And then a lot of work with our 2 acute hospitals around how we better get people into the services, how we make better decisions, and how we make that transition and that pathway work very smoothly. But a lot of that's happened at ICS level. So we're just at the point at the moment of defining the ICP strategies at place level and starting to have those discussions about, well, what of the outcomes and the principles and approach of our ICAM programme happen at ICS level, what happen at place level, and what happen at local area partnership level. And we've kind of done the small areas and the big area, and now we're kind of defining what that looks like in the middle. We've had a lot of success in terms of some of the outcomes that we've had of our programme. We've had a reduction in admissions in hospital. We've had some fantastic feedback from our carers, from our families and from our individuals who've been utilising some of the services that we have in the community. So starting to see some real impact. It's very clinical and care driven. We have a public and patient advisory group which is chaired by our voluntary sector organisations who input and feed into it. So lots of really exciting things are happening. Not to say there's lots of challenges, and I'm sure we'll get onto that during the discussion today. But really starting to define, well, how do we take some of the outcomes that we've been able to achieve at ICS level? How do we build on some of the kind of local engagement that we've had at local area partnership level and strengthen that level that is in the middle in terms of place, particularly with our 2 unitary councils?
Thank you. Lots of fascinating stuff for us to get into there. Really interested in the impact that you started to talk about there, Becky, so we'll come back to that as well. Thank you both. And I'm going to ask David just to share a few slides with us, which set out some of the work that we've been doing jointly between Newton and NHS Providers.
Great, thank you, Miriam. And good afternoon, everyone. I'm David McMullen. I work for Newton, and I've spent the last 10 years or so delivering transformation programs up and down the country. Integration at place is a really important topic, and I'm sure you'll all agree with Louise and Becky how important it is. For this work, we've pulled together insights from over 10 systems in real detail, and that's been a combination of specific reference sites that have come forward to be part of this work, such as Bradford District and Craven, and also programs, transformation programs that Newton have supported in recent years. So there's a real wide range of input and what people are feeling and experiencing in the sector that's gone into this. As we spoke to systems, it became really clear that the context of policy changes recently that Miriam discussed has set out this ambition for integration, and that ambition has been there for a long, long time. But we've hit a point now where there's been such a focus on our structures, on our setup and our governance and how those layers and structures work that we now need to make it deliver. And we're almost at that tipping point of we need to go from making that ambition into real delivery that's made a difference. And so we wanted to create a toolkit that brings together some real practical examples that's grounded in reality, examples of delivery that what's worked, what's challenging. And I think this quote speaks to that, moving from ambition to delivery. You know, if we're not focusing on what this actually means for the health of our communities in the coming years, then what's been the point of integration? So this pin icon that you'll see we've used, that pulls together the content for us and some of this thinking. We've got, starting with outcomes in the middle, we've got a ring of the common barriers people tend to come across in this work, and we've got our delivery of improved services underpinned by culture and leadership. Now, the reason we've laid it out like that is because we started to talk with our reference sites about this inside-out approach. And so often we start on the outside with a new delivery of a service. We might say, oh, we need a virtual ward, or we need an integrated discharge team. And we say, yeah, that's the right thing to do. Let's get it in place. Let's see what happens. And then we might go to, oh, what was the impact of that? Or did that change our outcomes? And we work our way in and we go to measure those outcomes, and we've come across some of those common barriers. And either it's been really difficult to measure that outcome, or the outcome wasn't quite where we thought it was going to be. So it goes without saying that it's as important in this work in place-based partnerships as anywhere else to start with outcomes and really explore what that means, to then overcome your barriers with those outcomes at the center of it, figuring, well, what is it about the barriers we need to overcome to get the outcome we're after, not to try and boil the ocean and solve that barrier in its entirety. And that will give us the delivery of services we're after. And just to dive into each of those in a bit more detail, we talk about outcomes all the time. It's always this is an outcomes-focused program. This is all about the outcomes. And I think one of the, what does it practically mean? What are you going to do next week to start with outcomes? Well, one of the things we found from speaking with people was that level of specificity. Often we see partnership working or programs of transformation that say, well, the aim of this is to improve outcomes. And that's not specific enough. How are we going to measure that? Which outcome are we after? We need to be thinking about, we are going to reduce our acute admissions by 11%. We are going to remove the inequalities of that particular outcome. We're going to avoid using those 150 community beds by having the right service for people in their own home. And having that specificity is absolutely key. Evidence and opportunity. In the work, you'll see we go into that in quite a lot of detail. Having that shared evidence base that, particularly in this partnership working space, that everybody is signed up to and everybody agrees with and believes in is really, really important. You need to keep that evidence base refreshed so we know where we're going. And the word opportunity, not just evidence that says we could be better, but an understanding of how much better. But how do we know when we're done? What do we think is the gap between where we are today and where we could be for that specific outcome, so we know when we're done. And finally, measures of success, and we're all very familiar with this as a topic, and one of the reference sites we worked with, they talked about setting up their recent community service in the Northeast, and they had 64 KPIs, I think, and 2.5 years later, with the benefit of hindsight, they were saying, well, that was not helpful. They had eventually, through some of these discussions and taking some of this approach, boiled it down to 4 or 5 KPIs that actually made a difference and that people could look at every day and every week and would be the levers towards achieving the outcome they wanted. So measures of success are really, really important. Moving on to that ring in the middle, these are the common barriers that we heard. And we've all been there. We've got a great program of work set out. We've got a really strong vision. We've got brilliant evidence of what could be better. And it's still really, really hard. And so what we've been able to do with this work is bring together what leaders and what yourselves are saying. Like, why is it hard? Can we start to boil that down? Can we put a bit of focus on the things that make it hard and then explore how people are starting to break through those barriers and what's working? So we've got workforce pressures, it'd be no surprise, competing demands and incentives, navigating governance and moving beyond that focus on structure and setup, lack of joined up data and insight at place, and historical ways of working and behaviours. And so in the work we explore each of those in more detail. Just to bring one of those to life, we take each barrier and we look at what is the reality being felt by systems and what we've heard through this work. We look at how systems are starting to overcome those barriers, and we've brought in lots of case studies and examples. And then we look at the shared learnings and the practical tools that are helping people break through. And there was a nice example here where Bolton, one of the places that have worked with us, they've really focused on changing that conversation and the culture around particularly finances and resources in going on their place-based partnership journey. And that has really, really helped them through this particular barrier. They've better prioritization of what needs to happen, and they're very, very clear on where the benefits lie and where the investments need to be across partners. So there's lots more like that in the content, and as Miriam said, hopefully you'll see some of the paper copies around this week. The final bit, and arguably the most important bit, is the culture and leadership. This has to underpin all of it. If we're taking that inside-out approach, it is the strong culture and leadership that stays committed to that vision and outcome we're after. So often we start and then we lose that sight and that energy and that momentum we had behind it, all agreeing the outcome we wanted to achieve. So the leadership has to drive that through. It is really important that we create the right environment for change, and we also look in the work about the importance of celebrating success. Leaders that we spoke to, they reflected that tension between their leadership role for their organization and their leadership role in the system. And I'm sure that's something lots of you have felt as we do more and more partnership working. And where we've seen the greatest successes of that, where we've seen systems really start to make inroads on this, they've had that really strong guiding coalition. It hasn't been a whole host of people, it's been a fairly small and tight group of the right people across the system from partners that even when it's got really tough, when COVID's hit or winter's hit again, they've committed and stayed true to that longer term outcome we were after from working at place and working together. And I know that sounds simple, but certainly particularly the work, some of the systems that are referenced in the work, there have been some really strong examples of that. And they've really, above all else, prioritized the strength and trust in the relationships that they want to keep even when it gets hard. So that's a quick summary of the work. I'll leave it there just to say thank you very much to anyone who is in the room from the reference sites or any of the programs we've supported. It's been brilliant pulling all of this together. I hope you enjoy having a more detailed look at it soon. And we'll pick up a conversation on Becky and Louise's experiences now.
Thanks, David. Perfect. it's really great to have that framework. I think that distills the learning from all the different places that Newton have worked with, so really helpful. So colleagues, be thinking about the questions that you might want to ask our panel. There's a couple coming through in Glyssa already, or we can do hands up in the traditional way in a few moments' time. That's absolutely fine. But meantime, I've got a few questions I want to get to the bottom of with the panel. So I think I'm interested in the start of your journey at Place. So tell us a bit about how you made a start. Did you pick a particular population for a particular reason? Did you pick a particular pathway for a reason? What was your starting point, and how have you developed from there? Go to Louise first, and then Becky perhaps.
Yeah, so we actually moved away from anything that felt medical and that medical model. And we'd previously looked at particular medical conditions and had very much our transformation focused around diabetes, cardiovascular disease, respiratory. But what we found was it tended to be medically owned. The population did not, when we went out to have conversations with our population and asked them what worried them, what concerned them, they did not come up with cardiovascular disease is big on my agenda, Louise. It was, and we had to flip it to really say, if we keep doing the same things and looking through the same lenses, we will keep getting the same outcomes. To actually start to flip to some of that prevention, early intervention, we have to reframe this around the things that matter to people and measure using the things that matter to people. So that was a really important concept in terms of how we were starting. And so we're having lots of conversations, and that will continue. Health Watch are on the journey with us. We've got a really strong citizens forum with us, and we plan to build that into our locality models as well. And the big advantage of those locality models being so kind of ingrained in neighbourhood and local authority working is that they're actually in all these communities having those conversations. And so we can really kind of link onto that. So, but the real ethos for us, it is about tackling inequity, but picking a few things that we need to get those outcomes on. And it might be around inequity of access and outcomes in the way that we measure them in the NHS, but it's about people being able to tackle them in a way that matters to them.
Thank you. It's a great starting point to be listening to communities and going from there, isn't it? Thank you. Becky, how about you? You spoke a little bit about over 65s, but I don't know if there are other groups.
So we particularly pick over 65s. It's somewhat similar actually to the moving away from the medicalisation of pathways. Because particularly in the over 65 cohort, often you'll find people who've got multiple medical pathways, and then if you're trying to deal with that separately, well then suddenly you're looking at people in different groups, and you've got clinicians saying, well that's in my group, and it gets a bit tricky. So partly because they are the population who are the biggest users of our health and care services. We've got one of the fastest growing over 65 populations in the country. I know lots of ICSs say that, but we have got that. We've got a lot of pressure on our acute services in terms of physical bed base, and they are by far our biggest users of that. But to Louise's point, one of the other things is when you go out and talk to people, they tell us the services are fragmented. They tell us they're not treated as a whole person. They tell us if I go from this service to that service, and we have quite a lot of our tertiary services are from Leicester or Oxford or somewhere else, and then they come into Kettering and they have a scan in Kettering, and then they have an outpatient appointment in Northampton. They get shown in A&E over here, and then they have a surgery over there, and every time they tell our clinicians the same story every single time, and then you get referred to the community providers and you tell the district nurse the same story. So we really heard a lot of that fragmentation, that frustration, that nobody is understanding what it is that is important to me as an individual and the baseline that's important to me, rather than the baseline that you think I should be getting to. So that's where a lot of our focus is on. So we've kind of got two sets of outcomes, if you like. One are some of the kind of hard metrics around non-elective admissions, and we particularly look at particular cohorts of patients that we're targeting in terms of specific services. But we also look at across the ICS in both of our places. We have our 10 Live Your Best Life principles. I'm sure most people have similar things around really understanding and getting that life as opposed to that health journey right, because you're more than just your hospital appointment and your GP appointment and the district nurse coming round. So really focusing and matching a lot of our measures that we've got on the ICAM programme to those outcome measures that we've got in terms of living your best life for the population.
Thank you. A lot of this ties into the panel discussion we had this morning, I think, doesn't it, around inequalities and that being at the heart of everything we do. David, is there anything you'd add there about helping people to get started, because you've worked with lots of different places?
Yeah, I think the points Becky touches on are not just those hard measures of discharges or admissions, but the softer measures, if you like, the more outcomes-focused measures, the measures that people would recognise and care about for their lives. I think that is harder, but it's almost where we need to have the focus. And I know through the work, applying some of this thinking in Bradford District and Craven, we were in a particular workshop with some of Louise's colleagues, and it was those real head-scratching moments of, oh, well, we want to reduce our inequalities, and it's going to be a great piece of work, and yeah, I love the invert the power to act idea, and let's go really local and hand that to them. And then we sort of, with this thinking, we just poked at that a little bit more and said, well, what is the measure? How are you going to know what that is? And to have that conversation right up front, I think that's the advice for where to start. It is start with that outcomes, and how do you start with outcomes? You have to define your measure, even if that is quite tricky, or we don't know where we're going and we don't know when we've got there. So colleagues in various systems reflecting how there hadn't always been that depth of thought put in up front to measuring those outcomes.
That's really helpful. So should we go a bit more in depth on the evaluation point then, and kind of outcomes? There are a few comments and kind of questions around how you're measuring the work that you're doing. So Becky, you probably told us the most on that. So you talked about non-elective and tracking some of the impact on hospital admissions. Is there any more you can say about how you're kind of tracking the work that you're doing and how it's feeding into outcomes and performance measurement?
I think it's safe to say actually measuring it is a journey.
Yeah.
That's been a bit bumpy along the way. And I think there is more data about our acute hospital, nationally, certainly within Northamptonshire. And it is tricky to get hold of and understand, and particularly actually to get acute colleagues to understand some of the measures that are set out in the community. We have, like most systems do, we have a system analytical platform that has data that feeds in from our different organisations. It has taken us longer than we would like to have got that set up and worked through the technical barriers and worked through the information governance barriers. But we now have a system dashboard. It doesn't have all the data in we would like, but it's got all of our acute information, and it's got our community services information, it's got information from our local government colleagues as well, which is particularly helping with monitoring some of those flow impacts, how many people are going home, how long has it taken them to get there. We've also put in place a patient feedback system, and that's kind of reported alongside, one of these rate your care sort of sites that gives us some of that softer patient measures. We have the vast majority of our primary care practices have signed up to put some of their data in as well, so we're just working through some of the measurements that are more in the kind of population health management space, where we'll be picking up some more of those outcomes. It would have been good to have had a lot of the data earlier on in our journey, and I think one of the things that's been particularly difficult, we talked quite a bit about trust, is building some of that trust in a case where people perceive that their organisational pressures are more acute than others because they can't see the data of the other organisation or don't understand the way that the data is constructed. And so we are now in a place where we can look at that holistically across the system. It has taken a lot of time, it's taken a lot of understanding, and there's been quite a few false starts in terms of getting to a place where we've got an agreed set of things that we can measure and we can track, and we're all looking at the same thing, thinking it means the same thing. So definitely still on a journey with that. I don't know if that helps.
Yeah, that does help a lot.
Just to expand on one of the barriers called out in the work is that lack of clear insight and data at place. And I think initially we explore you need to get on and start with something. I think so many systems have had a frustrating maybe 2-3 years on this journey, going, oh, I still have a PowerPoint deck that goes around once a week with some graphs copied and pasted into it. And people are in different places with this, but don't wait for the all singing, all dancing version. You know, pick the one page, the 5 measures that we will all agree with and can all get behind, and let's build it from there. Because focusing on the ones you need to see, that will get you over the bits of the barriers you need to get over. And then I think we also explored making sure you have the operational people in the room when you're looking at these measures. You still see examples of, you know, our digital and BI colleagues producing things in a dark room that aren't always that helpful or actionable. But vice versa, having the people in the room who do know this stuff that can let other colleagues know what is the art of the possible. And you know, there is so much that is possible these days. And you know, in one of our bits of work, we're exploring measures that wouldn't have been some of those hard measures a few years ago. Looking at a lot of the population health management approaches, we can predict 7 out of 10 people who are going to admit in the next 3 months. So that's given us a measure of saying, oh, well, nothing happened to those people. We looked after them in the community, but we've now got a measure that says, oh, well, we avoided those people going into hospital. We've avoided using those 150 beds. And so that's a new type of measure that's quite tangible for the person that, you know, has a lot of technical know-how behind it that we need to make sure is fed into those conversations as well.
Really helpful. I think one of the messages that came out was pick something and start somewhere, wasn't it? And see where it goes from there. Really helpful. So there are lots of comments, unsurprisingly, I think, about trust and how you build trust and how you build those relationships. So any top tips on how to build trust if perhaps it isn't necessarily there from historical relationships? I'm going to come to, I'm not suggesting you haven't got trust in your local system, but any top tips on how you build up that trust with partners?
I think it takes a lot of time. You cannot underestimate. Relationships are key to everything. They're the foundation of making everything work. And I think, you know, this is years of my colleagues and predecessors working together, you know, falling out together. And that's as important. How you find your way through the difficult stuff is actually really, really important. I think it's that being able to do what we say we're going to do when we're not in the room with everybody, because, you know, it takes years to build trust and seconds to undermine it. And I think that is so important to hold on to. I think the other thing that is really important is we've worked a lot, and I think the ICS changes have really helped us to have that collaborative mindset. But that can be at the top of the shop. And what is so important is that penetrates through all the layers of all of our organisations. And I think we have to be able to see it and feel it at those levels, and empower people working within our organisations to do the right things and to know that they are doing the right things. But I think it's important. We talked about celebrating successes, and I think that is really important to do together. But actually, the stuff that doesn't work is equally important to share together, to understand, but without a blame culture. And it is going to get harder and harder to have that collaborative mindset and to remain true to it as the finances get harder. And that's where we must stick to that values, the ethos, keep the relationships, that mutual accountability that we need to come back to will be really, really important. And I think, you know, some of the stuff around discharges with, you know, the social care, the challenges there, but also, you know, challenges within the NHS and working our way through that. I think how we do that will make or break relationships.
Yeah, it's really interesting. I don't know, Becky, if you want to add anything on building trust specifically, and then I'm going to come back to the sort of pool budgets and the finances and see where you guys have got with that work.
Yeah, I think it has to be at all levels, as you say. So we, as a group of boards in all of our different organisations, decided that we would do this programme, and there is real board level commitment across the board. But actually a lot of the work has been driven by our frontline clinicians and care professionals, whether that's in our local authorities working out in the reablement services or primary care, or on our wards in the 2 hospitals, out with the integrated care teams in communities. And they've driven a lot of this. They are the people who are leading our we have bricks and pillars in our programme. They are the people who are leading our bricks, and those recommendations, then that's what we as leaders within that are enabling their ideas. Let's get them the data, let's make sure that they are developing something that will work for them, and it's been very co-developed from that perspective. It is difficult though. We are, I'm just trying to work out how many sovereign organisations, we have 5 sovereign organisations in the ICB, and we do all have all of our competing pressures, and it gets tough, and the 2 hospitals are on Opal 4, and the local authorities have got, their own financial difficulties and pressures. All of us are really feeling the pressure, and it is easy to slip back and say, but we've got a really good leadership team, so our COOs and DASs across all of our organisations meet very regularly. We've then got a leadership team of executives that sits around it. And it's just coming back to why are we doing this? Is this still the right thing to do? Can we still see that these are the right things? And encouraging the openness and sharing of different people's problems and different people's perspectives. One of the things that we've been doing in the past 2 or 3 months actually is saying, okay, well, we've all got challenges right now. We've all got flow challenges, we've all got staffing challenges, and we've all got money challenges. How can we bring all of those things in the room and be more open than we've ever been before about how much does it cost to provide this care? Where are we putting the extra money in? Where are we all concerned about the things that maybe you might not wanted to have shared with your, old CCG colleagues, let's say, about where your own performance challenges are. And it is a journey, because there have been a lot of historical things around, we don't necessarily want to expose the things that we're less good at. But actually it's been really productive to say, we didn't realise that actually it cost us more to do that than that, and the outcomes are similar, or the outcomes are better and it's cheaper. And we can now start to make decisions. But it is really tough when it gets pressured to just keep coming back to what are the relationships, what are the things we're trying to achieve, and how do we do it together. But at the end of the day, a problem shared is a problem halved. And that's what we're trying to get to, but you have to work at it.
Yeah. And it's interesting what you were saying there about being more open book about the finances. So I'm interested if you've managed to create a budget at place, or if you've managed to move money around at all. Can either of you say anything on that?
So we've created budgets that sit at community level. We're still struggling to move money around the system. So we talk about left shifts of work, but resources following it. And at the moment, it's very difficult to actually move, particularly where we've got block contracts with budgets that sit there. It's a challenge. And we're trying to work through that at the moment and use some of our governance processes to support that. But what we have done is created budgets that sit at the community partnership level. The accountability for them sits at that 6 localities level. And what we've done, we'd created community partnerships before PCNs came along, and actually that knocked us off a little bit when PCNs came along, because then suddenly the money came down a more medical route than we'd gone down previously. So that took us a little while to really try and re-establish PCNs as one part of the community partnership, a much wider partnership. And I think now that we've got there, that's really helpful. So we've got budgets, and they're disproportionate across all of our all our community partnerships. So we've really looked at inequalities, at deprivation, and various metrics to say that certain communities would have a bigger resource than others. So we've got a resource that we had there anyway. We've created a community investment standard. Now, I went in for 1% of the total budget should come into this. I managed to get 1% of growth, but I'm working on it. There's some arms up backs at the moment. But actually, even that's a starting point. So when you look at what some of our community partnerships are able to do with small amounts of money, it is incredible. So we've got a community investment standard, and the idea is that we've got an ambition that this will continue to grow. That's really promising. And we've used the Core 20+5 funding as community-led. And then what we're developing is a framework that's light touch, so we're not using big system bureaucracy for small amounts of money, that sits at that locality level, so that we can say that, you know, we are accountable for that public pound and how it's spent, but we're allowing people to innovate, and we're also allowing people to try something and be proud of it failing and us learning from it and then moving on to the next thing.
It's really interesting. I think that's really innovative. Yeah. Becky, anything you want to add on bringing budgets together differently or moving money about?
So we have had all organisations agree to put money into a pot that we're then spending as part of the ICAM programme. So some of that is supporting the funding for our transformation programme that's driving it forward. Some of it is supporting services. For example, we've recently collectively invested in a new recovering independence bed model, which is a genuinely joint partnership between our community services and our local authorities to care for people with a wider cohort than we were able to previously. A lot of what we've done with money, I think, has been at system level rather than much more locally, and we're just working through what the framework for that will be as we transition into a collaborative with delegated powers, and how can we use things like expanding the scope of services in the Better Care Fund, which has obviously got an established framework, an established set of governance that operates at place level through the health and wellbeing boards, to drive some of that and push some of the more health funding and more health budget through that route, as a way of getting an integrated budget at place level that has appropriate governance without doing something much more complicated.
Thank you. And David, anything you want to add from anywhere else you've seen on your travels?
One of the reference sites for this work, it was the Chief Financial Officer of the Acute Trust, and I remember on this topic that they've done a very good job on this journey of, you know, a single pound, and she said, we're fundamentally still different organisations. We need to understand politics, and they need to understand clinicians, is what she said to me, and that's not going to change anytime soon. But what I've done, or what she had done, was just invest time to really understand them beyond being in a monthly director of finance meeting. She invested time and effort, and I really got the sense that, you know, they'd almost got under the skin of each other's challenges and finances in a level of detail, and that gave me a sense that had really helped where they got to.
Fantastic, thank you. Well, colleagues, I'm going to turn to your questions from the floor now, of which there are many on Glister, so I've plenty to go on, but I don't want to exclude anyone who doesn't have an iPad or a phone in their hand. So if you do want to come in, please just stick your hand up and we'll get a mic to you as well. So there is a lot of interest, actually, quite specifically around how people might engage with primary care colleagues in particular. So I think I might come to David first to see if you can summarise anything that you've learned from your travels, and then I don't know if the other panellists want to comment on that. I'll leave that open to you guys. So any different means or structures that you've seen to engage helpfully with primary care across the piece?
I suppose the simple answer is, again, engage them from the start.
Yeah.
When you're in that kind of evidence gathering stage, or even the specific focus stage, it's quite easy to not ignore, isn't the right word. It's quite easy to forget about various parts of the system, and primary care can often be one that we're not feeling that pressure, and the discharge pressures, the issues in social care. I think engaging them early, where we have done that, they've had a fantastic view, possibly some of the best views of those outcomes measures that will be tangible and meaningful to people, that are away from some of those harder measures that Becky mentioned. So I think, yeah, getting them in the room early, taking them through that idea of let's put a measure on this that's going to mean something for your communities. And I know, yeah, certainly some of the GPs in your area have been very hot on that.
Yeah, absolutely. I think for me, so I sit in general practice 1 day a week, so it might be a little bit easier not to forget the GP bit of it. But what is really important is I think sometimes GPs feel a little bit like the Cinderella service, that when we talk about it, the narrative is much more acute focused, and the GPs are the issue, or if general practice did that, it'd be much easier. So I think having a narrative that feels inclusive is really, really important at your starting point. But then there is something about being able to offer the opportunity. So, and I think there is a great opportunity with some of the PCN DES and the direction of travel around what PCNs are being asked to do. And there is, you know, for some of that, there is money flowing, but actually primary care are really head down, as everybody is at the front line. So the real opportunity is how do we take that and wrap around it? And that's where we can bring in a really strong partnership at those kinds of levels to support the population. And if we do that, that is your, you know, it starts to move people away from services, to demedicalise problems where we can, to get in earlier, to work with people. And I think that's the sort of key to primary care, to say this offers you something else. There is something that we can help to keep people out of your surgeries if actually we've got the VCS wrapped around some of these people. And we've got examples of where that works really, really well. But I think it's worth acknowledging that PCNs are still in their infancy. They're at really different stages of maturity. Some of the clinical directors have been doing management roles for years. Others are really new to it. So, you know, there's probably a developmental journey there as well.
Helpful though, it's good to know the history. And there's quite a bit of interest also about wider partners at the level of place. So I think people are interested which partners you've managed to draw in. So there are some questions about voluntary sector, education, housing, those sort of wider public services, and also a couple of questions about tertiary, whether you've got sort of representation from tertiary providers at place, or if you've not looked at that yet. I guess we might ask the same question for ambulance, whether there's a role there or not. So I don't know if you can tell us a bit more about the types of partners that you've got around the table. Maybe Becky first.
So our core leadership team is our local authorities, the toolkits, and our community mental health provider, as well as representation from our primary care colleagues, one of our largest federations. We've then got a wider engagement forum, which there are a number of different groups in that. So one is our voluntary sector. We are really fortunate. Northamptonshire Carers are a absolutely fantastic charity who support us and make sure that we've got appropriate co-production from our population in what we're working towards, and bring in patient and carer representatives within that as well. And they convene a voluntary sector, you know, with HUK and all of the other people in our area. We also have our EMAS and 111 involved. They're not involved in all of the programmes, but we do have some of our bricks that are related to, you know, how do we help reduce conveyances? How do we help make sure that they've got a good route to some of our integrated care teams so that they can come in? We're University Hospitals of Northamptonshire, so we have partnerships with universities. I think it's fair to say we probably haven't exploited that as much as we perhaps could do, and I think one of the things we're hoping to do is do more on what is that workforce model for the future, and how can we use University of Northampton in partnership with us to help build some of those skills gaps that we've perhaps got in the county. So I think probably more to do in that space. And then our two local authorities bring in housing and all of those other services at place level.
Interesting. Louise, how about you?
So yeah, we have different partners at each of those different footprint levels. So in our localities, we have our PCNs as part of the wider community partnerships. We have local authority in terms of, we have adult social care, neighbourhoods. We have our children and family hubs, community health providers, police, public health. and then looking at opportunities around more acute services within those. But we have a particular health and care exec forum where the focus is really health and care, but then that links into a wider wellbeing forum where we bring in housing and some of those that we refer to as wider determinants around that. And our tertiary, we would then link in, we would do that through our West Yorkshire ICS to bring in. So it's about that kind of doing the right things on the right layer and then sort of pushing up, escalating up where you need that wider group.
Yeah, it's really helpful. I think we need some diagrams, don't we? We have to share some diagrams afterwards, then you can see the lines of accountability as well, which some of you are asking about.
There's a couple of interesting practical examples on that point. You mentioned third sector. Without fail, in my experience, the third sector are delighted to get involved. And we involved one practically recently and did a study with them that said 45% of people being discharged from the acute could have benefited from third sector support that would have reduced their ongoing formal care needs. Only 9% had evidence of having that in place. So, that in itself as a bit of getting that evidence base that everybody gets behind. So that was great involvement. I think ambulance teams as well, there's some really exciting work going on. We're having that true pull model from your place-based integrated team that is actually pulling into the 999 stack and saying, oh, don't go and visit that person because we know them really locally and we know their needs, and the last thing they need is being taken to hospital. We'll call round and make sure they're okay. So some really interesting stuff going on.
Yeah, fantastic. And we've also got a few questions coming through about workforce planning in particular. So we've talked a little bit about how you're moving towards budgeting slightly differently. Have you seen any shift in being able to work with partners to plan for the workforce more effectively? Louise, do you want to take that first?
Yeah, so we're starting to do more with our colleges and universities. One of the things that we're trying to do is, so my ambition is a badgeless workforce. That when somebody says, who do you work for, there's not an organisation, it's the population of Bradford District and Craven. And that actually, it doesn't matter who commissions your service or which provider you're there from, you've got a team of people around you and you can actually help. And so that feels really important to sort of go down that route of that, get into that badgeless workforce, which for me, we're starting to do that with some joint roles. But there are real challenges around that. From a HR perspective, it's been harder than you should imagine it would be. But even just being able to co-locate teams. So I've got a bit of a test that if I walk into the locality hubs and open the fridge and there's one bottle of milk as opposed to multiple with different teams' names on, then we've cracked it. Honestly, that's my outcome. So there is something about that. If we can get to that where we can work as teams, regardless of some of the things that hold us back, IT, IG, HR, then that's where we'll start to wrap around people and really get the outcomes there.
Yeah, I love
we can add the milk as a barrier.
Exactly. Unless we've missed that out of the document, we'll add that. Yeah, no, really helpful. And Becky, you alluded then to working with the university, I think, around skills as a...
Yeah, and I think, like many other places, we've got big workforce gaps in various places across health and care. And what we are just working through, and it's become particularly acute as a problem in the last 2 or 3 months, we have extraordinary pressure in our 2 acutes at the moment. And like I say, our over 65 admissions are down. We're unable to discharge people home because of some of the challenges that we've got in our social care workforce in particular. So although we've got less people coming in the front door, we can't get them out the back. So the pressure in the acutes isn't any less. It's not helpful, and we're having to put in quite a lot of additional resource in our ED, in our urgent care pathway to manage the people that we've got there because of the risk that we're carrying. And we're doing a lot of recruitment out in community services, out in local authority services, social care services, to do that left shift. None of us want these people in our 2 hospitals. We want them in a more appropriate setting. Some areas the recruitment is working well, and others it isn't. And so how can we join together across health, you know, we are able to recruit HTAs within health. So how can we create some of those more joint roles, and what does that look like? With the flip side of that being, well, how is that going to unbalance, or is it going to unbalance the social care workforce and make ourselves a bigger problem somewhere else, because we've then got people who are doing similar jobs and similar T's and C's. And equally, we've got shortages, particularly around some of our therapists. So, you know, starting to say, okay, well, how can we get additional therapy skills through the University of Northampton? I mean, it's tricky because, you know, at the end of the day, at the moment, we've got a situation where in Northamptonshire, we've got lots of logistics. I don't know if you've been to Northamptonshire recently, but we're just levelling countryside to build logistics warehouses everywhere. And people are getting paid more to go and work in a warehouse than they are to go around and, you know, look after people in their own homes. And so it is really, really challenging in terms of doing that, balancing the various risks of the different partners. And I think that's one of the challenges that we really need to put focus on as a system, particularly going into next financial year, because unless we are able to better stabilise the kind of core social care workforce somehow, we're going to have continued risk and pressure on the acutes and on community services, which then starts to undermine, oh, well, we've done all of this work, and yet it's still really difficult in A&E, and that's when you start to get some of those fractious relationships. Sorry, I've drifted slightly, but I think the workforce challenge, that's one bit that we really need to focus on and make sure that we are building that workforce for the future, and we're looking after people, and we're getting those people with the skills in so that we can enable people so they're more independent.
I think everything's interconnected. Some of those challenges are policy asks as well, aren't they? I think for bodies like ours to be lobbying for. So really interested. So we're coming close to time, but I've got a couple more interesting questions to pose to you. So I'm interested in what your key piece of learning would be. So what do you wish you'd known at the start that you perhaps know now to share with the group? Please.
Wow. Everything.
Could be more than one thing.
I think it's probably understanding. So I think for me, it is understanding what the assets are that are already there. I think it's really easy. We can all articulate the problems and all of the issues, but actually spending time out in communities and taking the data, and I don't mean reams of data, but allowing communities to look at that population level, the meaningful stuff with them, actually is so helpful. And it is that bit about, it's about enabling, it is about that justice piece, it's about fixing the system for people, with people. It's not about doing two. And so I think, yeah, that starting with the communities, understanding what's there already that you can just tap into, or a tiny bit of resource, and it's not always money, can really enable and have a huge impact across the system.
Thank you. I'll come to David next and then back to Becky. Any thoughts from the various...
I mean, just picking up on the last couple of points, you guys have made the big things. There is no silver bullet, particularly to the current pressures that Becky was describing. The need to take that sort of twin track approach, whether it's workforce or anything else, but we absolutely need to have the long-term plan and get on with that. We're going to have to do something to get over the hump in the short term, and there's no sort of easy way around that, but we need to find a way to prioritize and be, I think somebody in the work said, you know, it's been as important deciding what not to do as what to do, and what can we turn off that lets us get over that hump, you know, particularly that, you know, the negative discharge cycle we're in of using up the services that actually make people better, and that just is putting more pressure on the long-term care market rather than less. So if we can free up a little bit, point it in the right direction, that turns that vicious cycle into a positive cycle.
Yeah, thank you. Becky, what have you learned from the last few years?
I think walking a mile in other people's shoes, and I sort of mean that from all perspectives, you know, walking a mile in the shoes of our patients and population and carers, and experiencing the world through the journey that they go through. And I mean, you know, people who work in hospitals and in social care, they've got families. If you go out, even if you just talk to the staff and just say, what was it like the last time your mum came in? You know, you will get all sorts of stories about what works and what doesn't work, and often it's as simple as the way that somebody spoke to me or how they explained what was happening. So I think from that perspective, but on the building trust and relationships across systems, the amount of community care clinicians and who understand what the pressures are like in A&E, and the amount of acute clinicians who understand the pressures that there are out in the community, people don't have the same perspective of that. You know, it comes from historical, the way that things operate within systems, and making sure that there are enough opportunities for people to go out and, you know, we only did it at the beginning, but, you know, go out, work in the community for a day, come into ED for a day, enough sessions where people can talk and get to know each other and just hear what it's like to work in the different areas. Because I mean, you know, yes, there are some differential pressures that are going on in our system, but I mean, the reality is everyone is under more, you know, feeling it, whether that's from burnout or pressure. And that's, you know, it helps to diffuse some of the blame, it helps to build some of those relationships and help people to understand what, you know, there's a lot of people in acute hospitals who've never stepped outside of an acute hospital. In terms of, you know, at leader level all the way down to, you know, clinicians, and the other way around. And so people's understanding of what it is actually like on a day-to-day basis, often there are things that somebody will come in and say, oh, I didn't realise you were having to do that, or, oh, you've got that data. So recently some of our community practitioners have come into our acute discharge hubs and gone, oh, we didn't know you had that, can you share that with us? Because then that means we can do this with it. And you're never going to find that at a system leader level, but if you bring the people in, then you can start to kind of work through some of those things.
Thank you. Well, thank you all, panel. I think that's a really fitting sort of ending for a really interesting conversation. So I think you're both inspirational place leaders, and thank you for coming to talk to us. I feel like we could have done a deep dive and learned a lot more about the work that you've been doing, so no doubt we'll revisit that. But thank you all for coming. Again, I think you can see the enthusiasm in the room for the unit of place and the work that people are doing just by the turnout that we've seen today. So thank you very much to our panel. Very struck by how you both focused on communities. That was your starting point, and that's really where we've ended the conversation as well. But some really interesting learning, I think, about some of the harder edge stuff, picking an outcome, how you've measured that, and some of the work that you've been doing around funding and finances as well. So thank you ever so much.